Let's look into the crystal ball a little bit. What's coming up? We don't know if the pandemic is going to subside soon or ever, or if there'll be a new one. Now, let's not get too doom and gloom. What are the options here in terms of the future existence or irrelevance of telehealth?
Now, of course, I'm an evangelist, right? And there's plenty of people out there like, oh, that silly technology is just going to die. It's not going to make a difference. Here's how I look at the ideal state, and the pandemic has let us start to play with that, right? One is that I really believe we should be looking at our entire care delivery model and saying which tool fits where. So for example, telephone calls, which we can consider telehealth, and email and video and remote patient monitoring and doc-to-doc consultations, those are all paid for by insurance companies pre-pandemic. But people were very uncomfortable to do any charging for email, telephone, and doc-to-doc because they just came about in 2019. So there was also a lot of misinformation. People didn't know it existed. So I really see looking at our entire care delivery model. So I'll give an example. Let's say I'm a patient who needs to see my primary care doc, and I need a script refill for something that does not require me to come in person. I'm a known patient. I'm a woman. I have UTI. I don't need 400 tests, but I need a script for that. In the world right now, we're like, well, you have to come in because I have to get paid for it. But instead, you could actually say, I know that patient and I'm comfortable to treat that through an email algorithm. Now we're even that much farther apart. And that email algorithm needs to be answered within 24 hours. Or I'm a patient who struggles with anxiety, but you know me and you might say, hey, I can do a quick phone call when you're having an issue and make sure you're okay. And then if I think you're not okay, I might progress into a video visit to really check how things are going, making sure you're not a risk to self and others, things like that. So if you really, as clinicians, they often forget that they do algorithm stuff all the time. It's just the algorithms in their head. So I was actually talking to a nurse practitioner the other day that she said, yeah, I ask the same 20 questions every time. So those 20 questions, we could put in an algorithm with the answers that allow you to make a clinical diagnosis. So I think if we can start to look at care delivery much more low, medium, high, and that we look at it much more as a path. So I'm comfortable with email, telephone, video, in person. And then we have remote patient monitoring on top for our complex people. And then we have this curbside consult, doc to doc, and really have a care delivery path and be able to be reimbursed for it all, because none of that is in this value-based. It can be, but why does it need to be when there's money on the table for it? What I will say is that's huge change management. That is big, big change in how we deliver care. And people will go back to what's normal because it's hard to make those processes. If you look at the Kaiser Permanente, the Geisingers, if you look at the groups like that of the world, they've been doing that for years because their motivation is more, how do I keep people out of here? How do I keep people healthy? So if we can start approaching it in that way, it can make a really big difference.
But it almost sounds like we have to turn doctors, nurse practitioners, anyone who's involved with the patient into like software developers. That's how a software developer thinks.
So I think you and I aren't clinicians, so like we can say that. If you say that to a clinician, I think it really scares them. So what I actually look at it is a different way. We need people like me and you who can ask the clinicians the questions to help them see how by using these other tools, they're still caring for people from their heart, practicing the art of medicine, and being able to get in front of, in person, the most sick patients. That's what motivates clinicians, is helping them see, I'm going to help you serve your highest need patients best. We don't tell them they're software developers at all because that would totally freak them out. Instead, we come from the heart center of how can you serve your highest acuity, most vulnerable people in person or with the tools that are most important. And then we will serve the lower risk people using more modern modalities.
You're absolutely right. And we are definitely in a point in our development of technology as a society where things have to be done seamlessly, otherwise it won't work. What do you think we're gaining out of technology adoption through the pandemic?
I actually think we're gaining connection. And although people may not realize it, I think we're also showing just healthcare that they can change. The people who shut down, the clinics and practices and outpatient, all those people who shut down, they didn't shut down because they had to. They shut down because they didn't know. The people who already had some kind of telemedicine in place or were willing to just wing it, they kept going. So all of a sudden they saw, wait a minute, I actually can do this. So I think we gain connection. I think we also show that our very traditional healthcare system doesn't have to be so traditional, that there are other ways to do it through these technology modalities. I actually think the conversation around interpretation, I don't know if it ever would have come without the pandemic, because I can't tell you how many places I work in where they're like, Sam, that's the interpretation machine. This is the telemedicine machine. And I'm like, well, I'm confused because the telemedicine machine can have a three-way call. So why can't we all be in here? When you get forced into these urgent spots, I think it teaches you. We're certainly seeing some surgeons and people who are realizing things I've been telling them for years. Hey man, you could do pre-surgery screens. You can do post-op appointments. How about we do those? No. I must touch them. I must do all these things. Now they're like, oh my God, this is working out great. I can screen 50 people and then I can get to the ones that really need surgery. All of a sudden they see, oh, here's the value of it. Now, on the flip side, we're seeing people who weren't well trained who are feeling disconnected because they're afraid to get on video. And so they're using telephone. And there's a big difference.
I have been an interpreter myself for doctor's appointments. I've done interpreting in person and I've done interpreting over the phone. There's a big difference.
Yeah, because if you think about it on a phone, you don't know when they stopped. You're not sure. And you're all kind of waiting for the next. Whereas on a video, you could see them when you're interpreting, especially if you're giving critical information, the clinician can be watching the patient in that moment as they're getting the information. And so they can go, oh, they're looking stressed. This isn't looking good. Or the family's looking this, or family. So it brings back that in person where they can watch the information be delivered and understand what's happening that you would never get on the phone.
Absolutely. The quality of communication improves undoubtedly because of where the people are able to focus. Now, I want to focus for a minute on something that I know is going to make you proud of the work that you've done and definitely makes us proud of the work we've done. By facilitating communication through patient care, whether it's one language or more than one, how do you feel that underserved communities have a better chance in the future through telehealth?
Yeah, this has been really fascinating. And there's been a lot of articles. The actual published data is coming out quickly, but we're seeing a lot of anecdotal data and newspaper articles and things. And so I've been seeing a lot of articles lately about telemedicine is leaving behind vulnerable populations. And now me of doing this 10 years, I'm like, I just don't think it's telemedicine that's leaving behind. So I go in and I read, what is this article getting at? And some of the common themes I see are, look, you started telemedicine, but you don't have interpreters inside of there. You're sending out all your confirmations in English, so no one knows what they're confirming. You didn't identify that they were non-English speaking, so you either just don't have an interpreter, or you just say, we don't serve people who don't speak English. That's not telemedicine leaving anyone behind. It goes back to, that's a process and a workflow issue that no one thought through. And so when I think about that, I also think, and then people say, I think there's some around Wi-Fi and broadband. I get that. But most people have a smartphone, an Android or an iPhone device, and most people have a reasonable amount of data. Do you have a smartphone or do you have a car? Which one are you more likely to have? And if you are a vulnerable population and you have a smartphone, no car, no babysitter, how are you getting to your appointment? So that in some ways frustrates me because I've heard for a long time, my Medicaid patients can't do telemedicine. They're FaceTiming with their friends. Like, I think we have some unconscious bias around what lower socioeconomic people of color can or can't do. And I can honestly tell you in 10 years of doing this, most people can do it. So when I've read this, telemedicine is leaving people behind, I kind of cringe because I'm like, Those are a lot of unconscious bias.
I'm hoping is that we'll start to realize much more as a society that we have to provide this access. There's just no excuse not to do it. We need to get our act together. We're leaving people behind. It's not fair. It's not legal. I'm going to give the show back to you, Sam, but I had some passion to get out there in terms of what I know that we're trying to do here at Ad Astra to help connect communities. I have some questions from the Ad Astra staff, and I think this is really cool. I asked them if they could just put in some questions, ones that we have here from Greg. And you can see a picture of Greg right here. Hi, Greg.
Hi, Greg.
He wants to know, what are the most frequent technical problems you see in telehealth?
So common technical problems are the easy ones. I can't hear you. I can't see you because I didn't test this in advance and I don't know how, right? But usually it's like unmute your mic. It's simple, but that is a barrier. And some of those barriers can happen because of the way you even configured your system. I could configure Zoom to mute you on your way in. Well, I would never do that in patient appointments because that would be a disaster. And sometimes people are like, yeah, but I don't want them to hear me. And I'm like, no, provider, just be ready. When you're on, right? Because turning mutes on and off is harder than everyone just coming in. Once you get there, we got to be ready, right? We're ready to rock and roll.
The next questions that I have here are from Hazel. She asked some incredible questions. She's a project manager in the translation department at Ad Astra. Now my dog's stuck in the office. All right. As hospitals start to reopen, will in-person appointments pick up again? Are hospitals, to your knowledge, leaning more towards remote appointments, including, for example, video remote interpreting, or are they more leaning towards in-person interpreters?
I think that it's really going to depend on where the hospital was before the pandemic in terms of their functionality of telemedicine. Right now, we actually are, some of the data is showing huge drop back down. And as I'm talking to people, we're asking, what do we think that is? We think it's probably a couple things. One is because there's still a lack of clarity on reimbursement, so people just go back to what they know. The other is we definitely have a pent up healthcare in-person need where people held off, and now they just want to go in. Otherwise, they maybe had already been offered telemedicine or they're not comfortable with it or whatever. So I think we are seeing this swing back. I absolutely would see one of the CTOs, so Chief Technology Officer at a big academic health system where I am, he said he anticipates leveling out at about 35% of visits being telehealth. And so if you ask me who's that 35%, well, whatever percentage of the population is going to need interpreting services is going to still need it. So I would say it's whatever percentage of the 35. Now you take another example of someone like a Kaiser Permanente. I mean, they literally went to like 90% telemedicine. I was like, just went way up. And now they're figuring out what's the right mix again. And they figure, again, 40%, they could probably stay pretty consistent at. And so again, you're going to have that. I think it's imperative that we have interpretation services. Like I've mentioned, I think they need to be a part of the workflow where you already know in advance. I don't think you should be waiting around like, oh, oops, now I have a Russian speaking person and I forgot to get an interpreter. Give us 10 minutes. I mean, that's all terrible workflow. It's bad for a patient. It's bad for the provider. It's bad for the productivity of the clinic. So I would love to see them integrated. I think this days of there's my machine over there, or there's my special phone, or these are all my bat things that were interpreters, that should go away because that's just more silos and it's not helpful and it's a disincentive to use either one.
Excellent. Thank you. One more really good question that I think is going to challenge us a little bit. Is there a platform that seems to be preferred by healthcare providers? What's our reference here? Tell us what you know.
Yeah, I think the thing is that whatever it was pre-pandemic is going to look totally different at the end. So even, for example, we use like a big EMR like Epic. Up until February, you had to have some kind of platform inside of Epic, whether it was Cisco or Doc on Demand or Zoom or all these things were in there. Well, then Epic decided they're making their own. So now they're going to have a video platform inside of that. I think Teams has really all of a sudden started to come up a bit because you have these giant enterprises that are already a Microsoft enterprise. The early version was horrible for video, and I know because I was tortured by it by many times, but it seems that the new version of Teams is good, or I haven't heard many complaints. No one knew what Zoom was before this. I've been using Zoom for a long time. Of course, when this started, Zoom had some security things that came up, so then people got nervous about it. I always hate to pick a winner because I have no idea. Like, it surprises me sometimes who are the winners, but it kind of goes back to what I said before about big hospitals. They're already going to have a certain amount of infrastructure. And so sometimes I'll say the selections aren't because they're the best. It's because we already have millions of dollars invested in this configuration, and we have knowledge on the team of how to use these particular tools. So we're going to stick with these tools. So I definitely think in big organizations, the best isn't necessarily what you end up with, because there's already large investments in infrastructure and softwares. And so, especially in big hospitals, enterprise devices, non-enterprise devices, on network, off network, these are huge challenges, things you have to solve. And so sometimes you may say, look, we already have Teams, we feel comfortable, we know how to support it, let's use that. And then it's the job of the telehealth people to say, is that really working right? I always say your minimum for tech working is 85%. And then your 85 to 98 is where you're improving what you do. If you have tech that doesn't work 85% of the time, you have a major problem. You need to fix it, or you need to get new tech.
That was a really awesome question, Hazel. By the way, Hazel, you're great. We love you. We're kind of getting to a point where we can start to wrap up, although we could go on for days. I mean, why not? It's almost as if you're right here. Though I will say nothing would beat a nice lunch at some point. Until then, our relationship will be able to be sustained virtually, and I'm really comfortable and confident with that. Anything you'd like to add that we might not have covered yet?
Well, I am just excited. I think this is a great conversation, and I think conversations like this really help. Whether you're the tech people, the administrators, the clinicians, we talked about a variety of use cases. We talked about what things can look like. And I think conversations like these are important because people have to understand, how would it work for me, right? Conceptually, you can think, hey, I guess I could get an interpreter in here, but you're not really sure what that looks like. So we talked about that. And I think that's really what can make a difference, is that by hearing that it's feasible, by hearing it's been done before, it can be done again, I think that helps put people at ease and be like, oh, okay, I could do this. We still have, in the States right now, we have a long way to go for management, and we have high risk people. Let's be real, COVID is affecting Black and brown people at much higher rates, lower socioeconomic, all these kinds of things that can be these vulnerable populations. And so the more we can do to use the tools to serve our vulnerable populations and make sure they have everything from language to the case management they need, they're not having to figure out how to get into clinic unless they must be seen in person. I think that's really our joy and our mission. And the more we can do that and use these tools that are commonplace on chatting with your friends or Facebook Live or all these things that seem really normal that we just hadn't brought into healthcare, this is our chance to do it. And, we might have needed to do it in more of an urgent situation that we had hoped for, but it can still bring us. So I'm thrilled to have had a chance to chat with you, and the work that you're doing at Ad Astra is awesome and it's exciting.
Thanks, Sam. Definitely mutual respect there. Tons of it. We're doing what we can, adding our grain of salt to be able to connect people. And this forum right here is a testament of that. So thank you very much.